Hey y'all, my name is Carrie Doge, and I am the instructor for the EMT class in Lake Charles. And I will be going over Module 5 material with y'all. So we're going to present some of the main points, the disease processes. You should have hopefully worked on the matrices that are also available to y'all. That's going to help you out tremendously when we start going over disease processes and trying to pick out really what the variance is for those. Concentrate on those unique findings, and it's going to kind of help you to, I guess, really kind of pinpoint which rabbit hole you're going down. Okay. After you watch this, if you have questions, you can put them in the chat on Canvas, or you can email me, K Doge, D-O-U-G-E-T, like letter K, Doge at acadian.com. Okay. So let me share my screen with y'all. And we can get this started. Okay, so we're doing Module 5. This covers chapters 15 through 20, and it's basically the first half of med-emergencies. There's a ton of material. Okay, this test is going to be hard just because there's a ton of material that we're covering in these chapters. Okay, so the first part, we're going to talk about chapter 15, which is shock and resuscitation. And you have a picture similar to this in your book. Let me see. It is on page, let's see. Guess I should have had that ready beforehand, but I didn't even think about that. My bad, y'all. In the 11th edition book is on page 440. It's different colors, but it's the same thing. One thing to kind of remember is the circles are types of shock, and the rectangles around it are examples or, I guess, categories under those specific 5 types of shock. Okay. So whenever we talk about hypovolemic shock, there's 2 different kinds. Obviously, there's the hemorrhagic and the non-hemorrhagic. Okay, hemorrhagic, obviously you're losing blood. So what we need to do, obviously, is stop the bleed. In non-hemorrhagic, you're not losing blood, but you're still losing volume. So this is like your patients that have nausea, vomiting, diarrhea for 3 or 4 days. They can be in non-hemorrhagic hypovolemic shock. Okay, so we're looking for those signs and symptoms. Your patients are going to be pale, cool, and clammy. They may have an altered mental status. They may have an accelerated pulse rate. So really look over at your overall presentation with your patient, okay? And then there's also burn shock is also in hypovolemic. We see this whenever we do third spacing. So you have 3 spaces that fluid is. It's either in the intravascular space, it is in the intracellular space, or the interstitial, which is your third space, which is the space between the cells. And so you'll hear people talk about third spacing, and that's in burn shock. Okay. Typically, whenever we talk about shock and we're dealing with the circles on this picture, they will either be, a patient's in shock, they will either be in shock for one of 3 reasons. It'll either be a pump problem, a tank problem, or a fluid problem. Okay, so obviously hypovolemia is a fluid problem. Moving on, we're going to go counterclockwise. So, or I'm sorry, we'll go clockwise. So we're going to cardiogenic shock's the next one, right? So obviously out of the pump, tank, or fluid, this is going to be a pump problem. Most common cause for shock on a patient, cardiogenic shock, is an MI, right? So obviously my pump is not functioning like it is supposed to because of the damage from that. It can be from CHF. CHF, dealing depending on if we're dealing with right side or left side, and we're going to talk about that in the next chapter that whenever we deal with cardiovascular emergencies a little bit more in depth, and kind of being able to tell between the difference of right-sided CHF or left side. Another thing, cardiogenic shock from beta blockers or calcium channel blockers and what they do. So patients are on these type of medications, and what it does is a beta blocker will stop the beta effects, and so your patient's heart rate is not going to be accelerated. And whenever we get into a couple other slides, and we're going to be able to tell the different stages of shock, it's really kind of a good thing, kind of a bad thing. Because while your patient's heart rate can't really get that fast, that is a compensatory mechanism that your patient has whenever they are in shock. And this kind of takes that away. Okay, so like if you have somebody that, I don't know, an 18-year-old or let's say 16-year-old kid, and they wreck mom's car, right? We get there, you expect the patient's heart rate to be elevated, their breathing rate to be elevated, their blood pressure should be normal to a little bit elevated. And then whenever we get there and this patient is on beta blockers for whatever reason, and their heart rate is slow, it's either going to be because they've lost all the volume and it's not going to beat fast because there's not enough volume to complete the circuit, or they're potentially on a beta blocker. Okay, so again, it's a compensatory mechanism. So that can cause cardiogenic shock. And then from an abnormal rhythm, like patients you'll hear in the field that they have atrial fibrillation. Some patients have, like, there's a whole bunch of, without getting into like a lot of paramedic material, like Wolff Parkinson's White, or oh my God, there's tons of different arrhythmias that can happen that can actually cause the heart malfunction. Okay, basically, without getting super complicated in that. Next, we have metabolic or respiratory. This one's kind of one that like we don't see a ton, but this can be from any other potential disorder. So like patients that are acidotic from gas exchange not happening like it's supposed to. Any type of respiratory disorder. These are people that can be like ARDS patients or acute respiratory disease. It can be from SARS. It can be like things like that. Okay. Moving on to the purple one, and we talk about obstructive shock. So this is not, if you look at the examples around it, okay, so tension pneumo, pulmonary embolism, and pericardial tamponade. This is an obstructive issue that is blood flow. Okay, it's a perfusion obstruction. So, for example, on a PE, it's not that the patient can't get the volume of air into their lungs. It's the fact that a PE is kind of like a heart attack of the lung. So there's a clot in the main vasculature of the lung that impedes blood flow, therefore oxygenation to get down. And what can happen is you can have ischemia and infarcts on the lung tissue. And if I can't oxygenate past the blood clot, then your patient can potentially die, and that's from a PE. Attention pneumo, if it gets big enough, obviously that's the life threat. We'll talk about that in respiratory emergencies in a minute. And then a pericardial tamponade, which can happen on its own, or it can happen from a tension pneumo. So just remember that obstructive shock is from perfusion and not necessarily, like on a PE, not necessarily just from something's obstructing gas exchange, a patient becomes hypoxic. Okay. And then we deal with distributive shock. So this one, these examples of this one are a little bit different. Okay. So we'll take septic shock first. So septic shock is whenever you have a patient, typically we see this in, a good example is our nursing home patients, right? They're bedbound, they're not getting up and moving. They get febrile, they lose since geriatric patients lose the dexterity in their chest to be able to cough things up. So they get some type of bug like a normal flu. They're unable to really cough up the gunk in their lungs. And so what happens is they're bedbound. They lay there. It's dark, it's warm, it's moist in their lungs, and it just breeds bacteria until the patient ends up with pneumonia. Well, then if the infection bleeds over into their bloodstream, then now they become septic. And so instead of it just being isolated like to their lungs, it is now systemic. Their whole body is basically just a breeding ground. So that can be septic shock. Neurogenic shock we see in patients that have spinal injuries. So if I have, I don't know, a football player that gets hit in the back, or somebody that gets in a wreck that's pretty significant and they have a lesion on their spinal cord, typically what happens is if you breach that spinal cord, then I lose the communication to my brain, which means that I lose sensory, you can lose motor, but you also lose vascular tone, which means that my vessels constrict and dilate. So above on the presentation, like y'all, whenever y'all were doing the spine board skill and you're testing pulse, motor, and sensory above on the upper extremities and then below on the lower extremities, pay attention to that, because in neurogenic shock, above the lesion, everything's good because you have vascular tone. So my patient's skin is going to be nice, warm, pink. Below the lesion, however, because they've lost that connection, then now my patient can be pale, cool, and clammy below the lesion because I don't have vascular tone. And then anaphylactic shock. This is one that we are looking for hives, itching. The difference between anaphylaxis and an allergic reaction is that if I get stung by a bee on my arm and it swells up and it gets hot and it itches, it's really painful, but it stays on my arm, that's an allergic reaction. Anaphylactic reaction now is whenever, again, it becomes systemic and I have respiratory compromise or cardiovascular collapse. So my patient's blood pressure is going to be crap. They're going to be, the breathing is going to be crap, right? Because they get bronchial constriction. The capillaries get really permeable. So my fluid shift takes place. And again, it's distributive. So that's just examples of my types. Remember, types are circles and the rectangles around are as categories of that. Okay, so just be able to differentiate where we're at. Our signs and symptoms of shock vary very little. Most of the time, again, my patient is going to show those signs and symptoms of shock. Okay, and I know that in respiratory emergencies, they harp on, you know, if it's 94 or below, then your patient needs oxygen. But that's just one piece of the puzzle. So look at your patient presentation and your assessments that you learned in module 4, and we're just going to kind of start putting pieces together. Okay. All right, so I'm going to get into stages of shock. So there's your compensatory shock, which means that your patient's body is able to kind of maintain things on its own. And then whenever we get in decompensated, then now your body's kind of letting go. And we, as pre-hospital care providers, really need to step up and hopefully draw the line between a patient being able to compensate on their own and me having to do things, right? Because the third stage is that irreversible shock, and basically that means that your patient's going to die. Some people die just because of the damage that was done, and there's really nothing that we can do about it, but we're going to give it our best effort. So if you look at the signs and symptoms on the compensatory stage, right? So this is like starting out. One of the earliest ways that you can tell if your patient is becoming hypoxic is a change in altered mental status, okay? Or alteration in mental status, rather. So my patient can be fine talking to me like I'm talking to you. And then whenever you become hypoxic, right? So like if somebody walks up behind you, chokes you out where you can't breathe, one of the first things that you do is you get restless, right? You kind of start fidgeting, you grab their arm around your neck, and like you're fighting to breathe, okay? It's the same thing whenever we do this. So if you look at the stages of shock, restless, anxiety, irritability, apprehension, right? It's because I'm not getting oxygen where I need to get it, right? The 3 things that your brain needs to be awake is oxygen, sugar, and space. And so if there's oxygen being depleted for some reason, whether it's I'm losing red blood cells or I don't have gas exchange capabilities, one of the earliest things that your patient is going to do is they're going to become really restless or they're anxious, and you're going to see it, that change. And then if you look at everything else, pale, cool, clammy skin, right? Pale, cool skin. Here we go. A lot of people, like whenever they first go in, they want to take a set of vital signs, right? And they're big on that blood pressure. Okay, blood pressure is the crossover from compensatory shock to decompensating. So if you're waiting for that blood pressure to change, you're behind the 8 ball. Look at the other signs and symptoms that your patient is exhibiting. Watch their mental status. Watch their pulse rate. Watch their skin condition. Okay. Then we worry about the blood pressure. If they have a radial pulse, I have end organ perfusion so that I know the body's not shunting. So it's really easy. Reach down and feel a pulse on your patient at the radial. Is it still there? Is it still the same condition as whenever you got there, right? If it's strong and bounding, then I know that the body's not shutting down organ systems and they're still compensating. All right. If you look in the decompensatory stage, the late signs, right? And you look at that, as you can tell, like the first one, listless, apathy, confusion, slowed speech, right? And you start going down, and about midway down, it says confusion, incoherent, slurred speech, possibly unconscious, right? This is because the brain is losing one of the things it needs to be awake, and it's oxygen. So we are just progressing. If you think of this slide as whenever you have, you're holding onto a rope, right? And you have a knot underneath your hands and you don't want to fall off the rope, and you squeeze as hard as you can and you're maintaining, you're holding onto the rope. Eventually your hands get tired, right? Your body weight plays a part in this. You just get exhausted and your grip starts to loosen. This is the same thing happening whenever my body is still compensating. My grip is loosening. So a lot of times whenever we try to readjust our hands to hold on, we're getting to the decompensating stage, and our hands get weaker and weaker and weaker as we hold on to this rope, and eventually we let go. Well, it's the same thing. Compensate, compensate, compensate. Your hands get tired. Your body gets tired. Things start to shut down. If you look at the list on the decompensating stuff, your body's just shutting down. And eventually it just lets go, and then it's irreversible. Okay, so just kind of as a mental image. Okay, so this is a shock and resuscitation chapter, right? So whenever we go into shock and we're able to like maintain things, and we're dealing with, you know, like preload and stroke volume and helping that cardiac output, and we're, you know, dealing with able to maintain and take the workload off the body. Okay. So prior to going into cardiac arrest, let me go back to this slide. What do we do in this to help take the workload off of the body? Okay, so we lay our patient in a supine position, because even whenever you feel bad, that's the position you want to be in, right? Like you want to lay on the couch and watch TV. Why? Because you're in a neutral position. You're taking workload off of your body. Your heart doesn't have to work as hard. You don't have to breathe as hard whenever you're laying flat. It's just comfortable. You do this. You just need to understand why you're doing this. So we lay our patients supine. We cover them up with a blanket, because as you look at this, and my body starts to shunt, and I pull heat away from like my fingers and my toes to keep my body core warm, then we're going to cover our patient with a blanket, and we're going to help them maintain some thermal regulation. We're going to put them on oxygen, because again, the signs that are on here, my brain is not getting the oxygen that it needs. And so that's going to change. And then we rapidly transport, right? Because our patient needs to be in definitive care. So you know what to do with this. You just need to know why we're doing it, okay? Because hopefully we can prevent the body from getting to this point where we actually go into cardiac arrest, okay? Hopefully, if this happens, someone recognizes it early, and then they are able to contact us, right, as pre-hospital care providers, because time is going to be crucial, and we need to be contacted as soon as possible for the best possible outcome for our patient. So if you look at this in electrical phase, it's less than 4 minutes following arrest. Okay, so my patient's heart is stopped. Hopefully somebody is going to jump on this and do CPR. Because what's going to happen is my patient's body is going to use up all its sugar and oxygen stores, right? So what little bit of aerobic metabolism is going to turn to anaerobic metabolism. So this is where we're at. So right now, what we want to do in this phase, my goal is CPR, jump on this, and circulate, take the workload off the heart, you circulate the blood, and hopefully prevent going into the circulatory phase, right? So this is kind of where we're at as we're going through this. Hopefully, can CPR bring the patient back? Maybe so. But 9 times out of 10, whenever your patient goes into cardiac arrest, they're in what's called ventricular fibrillation. And the best way to get out of VFib is to defib. So we really need someone to get an AED pretty quick and defibrillate that heart, hopefully, if that's the rhythm they're in. The circulatory phase, if you look at it, it's 4 to 10 minutes after arrest. And what happens is, again, we're in that anaerobic metabolism state, okay? And so right now, what we really need to do, again, is we got to circulate. So we got to do really good CPR at an appropriate rate, not too fast, so that way we can pull all the blood into the heart, push it out, and get that good circulation going. After 10 minutes, your heart goes into what's called a metabolic phase, okay? And unfortunately, at this point, this is typically by the time that we as pre-hospital care providers get there on scene in the ambulance, we're typically in this phase. And because of the stuff that's circulated in the patient's body, especially whenever you have a breakdown of myoglobin, then what happens is cells start to rupture and die, okay? Unfortunately, with this, what we need to do, you need to think about back to module 1, is they're rupturing and dying because that sodium-potassium pump has failed, okay? So we really need people to realize when to call an ambulance, how quickly to call an ambulance so that we can get there. Best other thing that we can do is they're on the phone with 911 and we get CPR going to circulate and keep the gunk out as best as possible. Right? The bad stuff from circulating through, because the heart doesn't like, a lot of potassium. Whenever your muscles break down, they release myoglobin. If you think about rhabdomyolysis, right, from doing P90X or CrossFit, a lot of people get really sick because of the rhabdo, and it's because of the trash that's circulating around in their bloodstream, and your heart just doesn't like it, okay? So there's different types of AEDs. There are automatic and semi-automatic. Whenever, depends on which one you have. The basic difference between this is if I have an automatic AED, whenever I put the pads on, it does all the work. It's going to read the rhythm. It's going to defibrillate the patient. It's going to do it all. Semi-automatic is the one that we put it on. It tells you what to do, but like you have to push the button. So the ones that you are probably practicing with at your site, okay? The big difference between adult and peds is please make sure that if you have a pediatric patient, you're using pediatric paddles on this, okay, the pads, so that way it's an attenuated dosage and we're not giving extra electricity to little tiny hearts, okay? All right, so just to kind of give you an idea of what's going on whenever you put the AD on, right? So we use an AD on patients that are pulseless and apneic. So they're not breathing, their heart is not beating. We're doing CPR. Y'all have done this skill 1,000 times in class. You're going to do it 1,000 more. But just so you know, like whenever it tells you that shock is advised, there's 2 rhythms that the AED recognizes, right? So this is why we don't touch the patient. So the first one is ventricular fibrillation, and it basically is my heart just doesn't, like the electrical activity through my heart is like, I don't know what's going on. I'm freaking out. And the heart muscle itself is basically just doing this, right? The ventricles are just, if you look at the rhythm, if you hand a 2-year-old a crayon and tell them to run down your living room wall, that's what a VFib looks like, okay? Sometimes it's really pronounced, and you could tell that you'll hear a paramedic say it's coarse fib, and sometimes it's really, really small, and you'll hear us call it fine VFib, okay? Doesn't matter if it's coarse or fine. The electrical system in my heart is just chaotic, so we're going to hit some electricity on it and hopefully kick it back into gear like it's supposed to. The second one is ventricular fibrillation. I'm sorry, ventricular tachycardia. There's 2 types of VTAC. VTAC with or without a pulse. Obviously, with a pulse, we're not even using the AED, okay? But without a pulse, if you look at it, you'll hear it referred to, we call it in the street as tombstones. And it just looks like if you looked at a field of tombstones, they're just big, wide complexes, okay? My atrium are not doing anything. This is all my ventricles. And again, it's not giving my atrium time to do anything. So we're going to hit it with electricity. There's no pulse to this. And hopefully we're going to be able to kick it back into where it needs to be. Okay. All right. So there are a couple rhythms. Contrary to what you see on TV, this is asystole. Asystole is not always just completely flat. Okay. There can be, like in this picture, a little bit of activity that the heart's not doing anything, right? This is the most stable rhythm you can be in because the heart's not doing anything at all. We do not shock asystole, okay? Grey's Anatomy does sometimes. Yeah, we don't. There's also another one called pulseless electrical activity, or PEA. And this one, PEA, can be any rhythm. It can be a beautiful, normal looking rhythm, but if there's no actual pulse, because there's electricity on PEA running through, but there's no actual mechanical function of the heart. We do not defibrillate that either. We're going to do CPR. We're going to give epi. You're going to call for an ALS unit. We're going to do a few other things for that patient, but we do not shock asystole or PEA. Okay. All right. So let's talk about peds real quick. So typically peds, whenever pediatric patients are born, they're all new and shiny. Their hearts are strong, tough as nails, and they should be just elevated. So typically children go into cardiac arrest for one of two reasons. So they will either be because of a congenital issue or respiratory in nature. So as pre-hospital care providers, we really want to keep pediatric patients breathing, whether you are bagging that patient or they are breathing on their own. Okay, children compensate for a very long time. Their little toes get on the edge of the cliff. They can maintain their balance for a very long time, but whenever their little toes give way and they go over the cliff, it is very hard to get pediatric patients back. So please make sure that we are doing compressions whenever we need to. You're going to go over pediatrics more intensive in module 7. So it'll kind of give you a little bit more of a background on those, but just remember that we really want to keep pediatric patients breathing and make sure that we are doing the compressions adequately on pediatric patients. Okay, so let's get to the respiratory chapter. So that was kind of shock and resuscitation. I don't think there's anything else. Let me look through this. Oh, let me talk about, okay, to know, remember, whenever we talk about the chain of survival, okay, on cardiac arrest patients, again, the sooner somebody realizes that something's wrong, that's the first step. If they can call us or call 911 quickly, CPR is going to be compressions. If in the United States, if you had a state to go in a cardiac arrest in, it would be Washington, Seattle, Washington to be exact, because everybody over there knows how to do CPR. They've been through a class. Most people are certified. There are AEDs on everywhere. And they're trained whenever they call 911, they already have it in the system. Hey, I'm at 1234 Oak Avenue. Okay, look on the corner there in the brown building on the second story. There's an AED. Go get it. Like they're just great. And they know how they jump on. They do CPR. They defibrillate people. And it's like a 65, 75% survival rate. Okay, which is incredible. So the sooner that we can get definitive care for that patient, the better. Okay, so just kind of wrap that up. All right, let's move on to respiratory emergencies. Okay, so let's talk about the things and the differentiating the disease processes. So this is just a real quick review. This is going back to module 1. I'm not going to hit on this very much. I just want to show you this photo. Just make sure that you can remember this from module 1, chapter 7. Okay, that you can differentiate the structures of the upper airway. Remember, the cutoff is my cricoid cartilage, which is roughly about where my vocal cords are. Anything above that is upper airway. Okay, go back and look over this for you to be able to remember structures. Remember that anything that ends in pharynx is basically like a living room. Okay, so it's like a shared space. So nasopharynx, all your nasal passages go to that back living room. Okay, and so on. Structures of the lower airway, again, just a picture to go back and make sure that you go over this again if you don't remember what's in the lower airway, okay? Because there's difference in sounds that you're going to hear for upper airway obstructions and lower airway obstructions. So go back over this if you need to. All right. Some of those sounds that we hear, obviously, this is all lower airway sounds. I didn't put upper airway sounds on here. I apologize for that. Okay, but I'm going to talk to you about upper airway. If they're not on here, I will fix that. Okay, So wheezing is, these three sounds right here are all lower. So wheezing is that high pitched sound, okay, that you get like asthma patients, and it's bronchial constriction. Bronchi, think of it as like thick mucus. Okay, so these are those patients that we get to the nursing home, and our patients are laying in bed, and it's like that sound, right? It just sounds like there's so much thick crap in their lungs. You're like, my God. Even if you just sit these patients up and you drop that crap to the lower bases where they can actually have gas exchange on the top part of their lungs, helps out tremendously. Crackles or rows, think of it as thin. It's more like whenever you blow into like milk or bubbles, and it makes that thin, watery sound. Okay, so bronchi is thick mucus. Crackles or rows are like thin water. A couple upper airway sounds. So stridor is one that's way up high. That's like from foreign bodies or epiglottitis. So it's that high pitch that when somebody takes a breath in, right? You have obviously gurgling, which is fluids. We need to suction that. Stridor, or you have snoring, okay, which is like the tongue. So typically, like if you have someone that sleeps next to you and they snore, instead of elbowing them, if you reach up and like actually pull their jaw forward, if you directly lift the jaw, the mandible forward, you indirectly pull the tongue off the back of the airway and they'll stop snoring. Okay, so that's just some adventitious or abnormal breath sounds. All right, so let's talk about some disease processes. So COPD is an umbrella term. Okay, and it is, if you look at this picture, the normal alveoli, okay, people refer to them as like little bundles of grapes or whatever, but your alveoli are here and your capillary beds fit just like perfectly around it, okay, because this is where gas exchange happens. And gas exchange, it has to be between the alveoli and the capillary. It's one cell thick, okay, so it's got to be really, really small space for oxygen and carbon dioxide to kind of pass back and forth, right? So if you look at emphysema, what happens in emphysema is that these people, it's kind of like if you blow a balloon up. So if you blow a balloon up all the way and then you let it out, and you blow it up and then you let it out, you know how like on the side it gets kind of wrinkly? Okay, so it distorts the little pockets that my capillary beds can fit around, right? So they kind of get distorted, and then my capillary bed doesn't fit like it's supposed to. And so because of the fact that I've decreased that surface area, I can't have the gas exchange like normal, okay? Emphysema patients, whenever we deal with them, you're going to hear them called pink puffers, okay? So I know it's kind of weird, but that's what they call them, right? So these are the people that are like really, really thin, and they're barrel chested. So like they got a big barrel chest, like little chicken legs, right? And they're pink puffers. So whenever they breathe, they're going to do that whole, they breathe it through pursed lips. And if you do that, like if you just did it like right now, take a big breath in through your mouth, and instead of just breathing it out normal, like purse your lips and really feel what's going on, right? So you're basically like self-CPAPing because you've changed the pressure in order to get the air out. And if you feel it, you also kind of use your abdominal muscles to push up against your diaphragm to try and get all the air out that would normally come out, okay? So they're barrel chested, they got little chicken legs. Some of these people obviously are going to have, they're pink because they have a retention of carbon dioxide. So they kind of have like a normal like pink hue to their body, but they're puffing. Okay. These patients also, whenever we deal with them, these are the ones that whenever we get there, they're like in a tripod position. They're self-CPAPing, so they're pursed lip breathing. These are the patients obviously that have smoked for a pretty good amount of time. So they may or may not have like a cough with that, okay? On the contrary, we have the chronic bronchitis patient. So chronic bronchitis starts with a B. They're blue bloaters, okay? So these are the patients, whenever we see them, again, this is by smoking. And what happens whenever your lungs get super irritated is they produce mucus, right? So chronic bronchitis, these patients like have their bronchioles are inflamed. Anything that ends in itis, remember, is inflammation or irritation. And so they have this chronic mucus production. So these patients will cough because they're hypoxic. And remember, it's not one cell thick anymore. It's way more than that. So because it's thicker, gas exchange can't happen. And so they're blue. So they have kind of like a blue tint to them. It's not going to be like Smurf blue, but they kind of have that blue tint to them. These patients too, because of the fact that they are on medications, they're usually going to be on a steroid for the mucus production and the chronic. Obviously, if there's mucus in your lungs, remember you've got prime breeding ground for crap. So these patients are usually kind of bloated looking because of the steroid, right? So they're blue bloaters. These patients will cough. They'll be able to cough stuff up. Remember that anytime a patient is coughing, I want to know all about it. Anything that comes out of a patient's body, pink, whether it's pee, poop, or they're coughing stuff up, I want to know what color it is, how long it's been going on. Like we're going to talk about all that gross stuff that comes out of people's bodies, right? And so if you're coughing, I need to know how long have you been coughing? What are you coughing up? What color is it? And did they smoke again? Okay. So if you're doing those matrices, emphysema, pink puffer, chronic bronchitis, B, blue bloater. Okay, so that's that's one of the unique findings. Okay. I think that's it on that. Okay, moving on. We're going to talk about asthma. So the thing with asthma is these patients will know just because they have asthma does not mean that they are having an asthma attack. Okay, you need to really, any patient that's having shortness of breath, you need to listen to their lung sounds. Okay, this is going to be that wheeze that's going on. Okay, so if I'm hearing rhonchi in there, it's not just because I have a history of asthma does not mean that that's what's going on. Look at the other signs and symptoms. Okay, so asthma patients are going to be wheezing because of the bronchial constriction, which is why we give albuterol. Right, we need to bronchial dilate these patients. Yes, they can have mucus production. Not all asthma patients do, where they have some big, coughing episode and they're going to cough stuff up. It can, because remember the irritation of the lungs is going to cause mucus production. So just depends. These patients also will, this is where I'm going to look at their O2 sat. You're going to talk about their trigger. You're going to ask them if they have done any of their own MDIs. That's from module 4, right? So it's not just albuterol. Some people take ipratropium. Some people take the long-lasting inhalers. Like whenever you listen to the commercials on TV and they talk about this is not a rescue inhaler, because typically the longer-lasting ones have the steroid mixed in on them, and so it helps to keep their bronchioles open. Okay, so that's asthma, wheezing. Can be mucus production, a decrease in O2 sat. But typically whenever we deal with these, this is like an acute onset, right? So it's not going to be like, oh yeah, it's happened over a couple days. No, this is like I was mowing grass and all of a sudden couldn't breathe. Hey, pneumonia. So pneumonia patients, one of the big unique signs with these are, yes, they're going to be short of breath. Yes, they are going to potentially have mucus production and coughing things up. And yes, it's going to be brown. But unlike chronic bronchitis, these patients will typically be running a fever. Okay, so unique finding associated with the shortness of breath is running fever. Again, these patients typically, they may be kind of clammy, but again, we're talking about when was the onset of this? Have they had fever? How high is their fever? Are they treating their fever? What are they coughing up? What color is it? Same thing, okay? Let's see. Remember too, though, with this, it can be viral, not necessarily bacterial. So you need to protect yourself. If my patient is coughing and they're coughing things up, remember that a lot of respiratory disorders are caused by air droplets. So you need to make sure that if nothing else, your patient has on a mask or you do. You also, if you're immunocompromised and you're the one with the cold or whatever, you don't want to give it to your patient and complicate them, okay? Especially since pneumonia patients, we deal a lot of nursing home patients that have pneumonia. And remember, they're the geriatric patients. They don't have the ability to fight off infection and cough like we do. So just keep that in mind. Pulmonary embolism, we talked about earlier, that it's an obstructive issue, right? So here's an example. So if you look at it, it's in the blood vessel. It's not in my bronchioles. So my patient can potentially still get like a whole volume of air breathed in. This is going to prevent gas exchange. Okay, so these people will have an acute onset, sharp stabbing chest pain, right? These patients will also, whenever we're asking their history, if they're female, fertile, and over 40, and a lot of times if they're fat females, fertile over 40, that's one group of people that are more prone to PEs because of people that are also on females that are also on birth control. This is one of the potential risks whenever you take that. People that have had surgeries within, like recently within 6 weeks, people that are, if I decide I'm going to drive from Lake Charles all the way to Disneyland, right, that's 13 hours. You need to get out and walk around. One, because I'm going to need to go to the bathroom because my bladder ain't that big, but also to keep the potential for a PE from not happening, right? So that's something else we ask our patients in their history. Have they traveled any long distances? Have they had any recent surgeries? Do they smoke? Females, are they on birth control? Okay, so we're asking those things because this is a risk factor for a PE. Pulmonary edema. Okay, so you can get flash pulmonary edema on these patients that have heart failure, and whenever they have left-sided heart failure and it's backing up into their lungs. Some people, if you look at the difference in the pictures, some people that get pulmonary edema have other issues going on, so they have some type of cardiac issue going on. So respiratory and cardiac emergencies kind of work hand in hand. But if you look at the difference in the two circles, so the one on the right side of the page, where again you can see where oxygen and carbon dioxide, the capillary bed sits right up against that alveoli, and remember it's 1 cell thick. But if you look at the other circle, then you can see where the fluid actually is in between that, and it's not going to allow the gas exchange to happen. These patients sometimes, if it's really bad, will present with like they actually are like blowing bubbles out of their mouth, and it's not just in their mouth, it's actually coming out of their lungs. So you can have blood tinged sputum that comes out of these patients' mouth. We really need to bag these patients, drop an advanced airway, call for ALS backup, because these patients are basically drowning from the inside out. Spontaneous pneumo. So if you are tall, lanky, thin males are the most prone to a non-traumatic spontaneous pneumothorax. So these are the patients that have like an acute, they're playing basketball and all of a sudden an acute shortness of breath. They can't breathe. If you look at this patient, his left lung is the one that's actually collapsed. And it's because he had a bleb just from growing so fast. And it's just like a weak spot, right? Like a water hose that gets that little bleb on the outside and it ruptures. So whenever I listen to lung sounds, my patient, this patient right here, listen on the right, I'm going to have good breath sounds. I listen on the left and they're going to be diminished. Okay. No trauma, didn't get hit by a baseball bat, didn't get stabbed, shot, anything like that. And there's a potential for there to be a spontaneous pneumo. All right. We've taught y'all through class that if you have that has excessive secretions, that we need to control them and you need to suction. This is the one caveat to that. These are typically, you can get epiglottitis as a grown-up, but typically these are children. And these are the children that whenever you get there, mom is going to tell you that, well, he's had a ear infection or an upper respiratory infection. He was fine whenever we went to bed. We wake up at 2 or 3 o'clock in the morning, and suddenly now he's crying inconsolably. He's drooling excessively. He's running fever. I just don't know what to do. Okay, so whenever you get there and you look at this child, he's going to kind of be leaning forward. He's going to be sitting on mom's lap. He's really not going to want anything to do with you. Remember that with pediatric patients where strangers coming into their space. He's really just not going to want to have anything to do with you. These are the children that you need to keep in mind. It is not your shirt they are drooling on. Let these kids drool. The problem is epiglottitis is inflamed, and remember that's the gatekeeper. Lets food and drink go into your esophagus, into your belly, and it lets air go into your trachea to breathe. So these patients, because of the fact that it is so inflamed, it hurts to swallow. So these kids don't want to swallow. That's why they're drooling. Okay. Let them drool. If you suction this and you get back in his airway and you cause laryngospasm, what's going to happen is mom is going to be holding her child. He's breathing. He's crying. He's fine. You mess with him. You suction. You cause laryngospasm. You have now let mom hold her baby while this child takes its last breath. Because with laryngospasm, there's nothing you can do. You need to call for ALS backup, because all I can do is stick a coffee stirrer in his neck and hope that he can breathe through that till we can get into the hospital. Okay. So these kids, do not suction these kids. Just tell mom, hey, grab a shirt. We're going to change him at the ER, whatever. Let this kid drool, sit on mom's lap, ride in the ambulance. Okay. If nothing else, we can hold blow by oxygen by his face. You don't even have to have it on, because again, we don't want to irritate this kid where he coughs or cries and it causes laryngospasm. These kids are it's pretty hairy to deal with these kids. Okay. But just think about that. Moving on with cardiac emergencies. Okay. So again, you need to be able to trace a drop of blood through the heart. Okay. You really need to look at these structures. This picture is in your book. I don't know what page it's on, but this is in your book. And you need to be able to make cue cards or whatever it is on page 523 in the 11th edition of the book. You need to be able to, you will be asked a question about this. I don't know if it's on exam 5, if it's on the final, where it's at, but there is a question that, let's say it's going to say, hey, you have a drop of blood that is leaving the lung. What is the next structure it goes through? And you need to be able to say, oh, that's my pulmonary vein. It's going to go into my left atrium and then blah, 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 blah. Okay. You need to be able to tell which valve is which. Tricuspid is on the right side, right? You got to try before you buy. So tricuspid is on the right side, bicuspid is on the left. Trace the drop of blood, go through the main structures. Vena cavas into the right atrium, through the tricuspid into the right ventricle. It goes in through it's going to my lungs, so it goes through the pulmonary valve, through my pulmonary artery. Remember your pulmonary artery. Arteries carry blood away from the heart. Pulmonary artery is the only artery in the body that carries deoxygenated blood. Goes to the lungs, comes back to the pulmonary vein. Veins carry blood back to the heart. Pulmonary vein is the only vein in the body that carries oxygenated blood. Goes to the left atrium, bicuspid valve, left ventricle, out the aortic valve to the aorta, out the body. You need to be able to trace that. Okay. Electrical system. Know that the SA node is the pacemaker, right? It is the gatekeeper. It is the key to the heart. You need to make sure that you know that typical beats per minute out of the SA node is between 60 and 100. Anything below 60 is bradycardic. Anything above 100 is tachycardic. So just to keep it easy to remember, 60 to 80 is typically what most people are in. Okay, 60 to 80. It goes through to the AV valve, to the atrioventricular node. AV node is next in line. Its rate is 40 to 60. So there's another 20 beat section, right? AV node. And then it goes down through the bundle of His, through the ventricular septum, into the Purkinje fibers, which they're the last ditch effort for you to have electrical heartbeat. And it is 20 to 40. Okay. Okay, so real quick, without getting into major specifics on what the EKG is, just so that you have an idea of really what's going on with the electrical system of the heart, and some fancy pants words, right? 50-cent words, depolarization, repolarization. So what exactly does that mean, right? Depolarization basically is the contraction. Repolarization, R, is like when your heart rests, R, okay? So P wave is the first upbeat off of the isoelectric line. So it is whenever your atrium, are depolarizing, right? Or your atrium are contracting. Goes next to the QRS complex, right? This is whenever my ventricles contract. Well, if my atrium contract, at some point in time, they have to repolarize or rest, relax, right? Because my QRS is my ventricles and is a bigger current, then the EKG picks up the bigger current. So while my QRS, while my ventricles are contracting, my atrium are relaxing, right? And then it goes to my T wave, which basically is everything resetting. So my ventricles are relaxing, my atrium are fixing to contract again, and then it goes on and moves forward, okay? Very basic. If you want to know more about this, get into the paramedic class. The cardiology part of the paramedic class is very in-depth, and it's going to kind of teach you what every little part actually means and how wide it is and everything, okay? But this is just to kind of give you an idea of what's going on with the EKG. All right. There are some main vessels that you need to know. So obviously carotid arteries are going to be important. You have internal and external, but the carotid artery is a pulse point. It's a central pulse point that we use. And typically, if I have a carotid pulse, you can have at least a blood pressure of 60 systolically, so that I know that while my body is shunting, I at least have some perfusion, right? Go down to brachial pulse is going to be one that is going to be important, especially with pediatric patients. This is where we check our pulses on anybody that's less than a year old. You'll know the radial pulse. Radial is on your thumb side. It's also important to know that whenever your aorta comes down at your belly button, it's actually at the iliacs, right? Which if you think about it, goes across to where your iliac crest are, which is the level of your belly button. And then as it passes through your pelvic girdle, it goes down to your femorals. Popliteal is important because it's on the backside of your knee. Goes down to posterior tibial, which is the one that runs behind your ankle bone or your malleolus bone. And then the dorsal pedis is the one on top of your foot. All right, so let's talk about ACS, acute coronary syndrome. If you look at this picture, and you also have this picture in your book, sometimes patients have just, like, you can have an elderly female that's just complaining of abdominal pain. That doesn't mean that she's not having a heart attack. It just means that this is where her body is picking up the pain, right? Or the discomfort, right? There's a difference in pain and discomfort. So if you look at these pictures and you're looking at, man, it doesn't, there's like, you know, not just, oh, middle of my chest hurts, crushing pain radiates to my jaw and my arm. There's several different ways that your patient can actually present and be having a heart attack. So this is why if you work on an ambulance, you're going to see your paramedic partner. If I have a patient that has abdominal pain, we're going to run a 12 lead on them just to make sure that it's not some type of cardiac issue going on, and that's just the way that their body is presenting with the pain. Okay, just kind of give you a reference. So let's talk about angina. There's stable angina and unstable angina. So if I have a patient that's having angina, it's chest pain. If it's stable, it goes away with rest or nitro. So if they were in the yard mowing grass or whatever, and they started having chest pain, and then they went inside and sat down and drank a glass of tea and rested in the air conditioning and went away, then that's stable angina. If they did that and came inside and took a nitro and it went away, that's stable angina. If it, now I go in, I rest, I take a nitro, it doesn't get any better. I wait 5 minutes, I take another nitro, it doesn't get any better. Okay, we're on unstable angina. We're kind of leaning toward a potential MI. So if you look at the difference, you have this picture in your book as well. On page 531 of the comparison factors between angina and MI. And they're really and truly the same until you get down to the fact that if you walk in and your patient is like sweating and they're kind of gray, they're pale, they're clammy, we're not angina anymore. We actually going toward that MI. If it's lasting longer than 15 minutes, okay, some say 10 minutes, then we're leaning more toward an MI and not angina. All right. So just kind of, again, whenever we're getting that history, it's very important that we ask about how long this has been going on and have they done anything, or does anything provoke anything, make it better or worse? Okay. What's the difference between an abdominal aortic aneurysm or an aortic dissection. Well, I kind of just told you. So an aortic aneurysm, in the field we call it, you'll hear them say it's a AAA, and it's an abdominal aortic aneurysm, and this is because this is where it typically is. So these patients, whenever we're doing the check on their belly, you may potentially feel a pulsatile mass, and it's because that's the bleb that you're feeling, okay? So if you feel that, some patients, in fact, know that they have a AAA, and the doctor's just watching it, which is crazy to me, but you know, I have something that potentially, if it ruptures, my patient's going to bleed out and there's nothing I can do about it. I don't know. If I had one, I would want it fixed. Please, we're not just going to watch it. But if you have that, check the pulses in the patient's feet simultaneously and see if one is stronger than the other, okay? And it kind of just tells you if they are and it's like significantly different, then there's a potential that it's a significant bleb, okay? An aortic dissection, typically what happens is there gets to be a tear on the inner lining of the aorta. And then as the blood comes down, because it's such a high pressure area, it just starts to tear that interior wall. So these patients are actually going to tell you, I have this ripping, tearing sensation in my chest because that's where the aorta is the most high pressure. And it radiates to between my shoulder blades. Like it just hurts really bad. It feels like it's ripping. It's in between my shoulder blades. Okay. So CHF. So we deal with right-sided and left-sided CHF, right? It's heart failure. My pump problem. It's not working like it's supposed to. So if you look at these signs and symptoms, again, you have this picture in your book. But if you look at the signs and symptoms and you look on her right side about her elbow and it says, may cough up pink sputum. Okay. So this is, it's in my lungs. So left lungs, L and L, right? And if you look on her left side down like toward her knee and it says pedal or lower edema, lower extremity edema. So right Reeboks, like the Reebok shoe. So if I have a patient, whenever, again, they're short of breath, you listen to their lungs, I have fluid in their lungs, then we need to think about potentially it is a CHF. And the gold standard for treating left-sided CHF is CPAP. Because we're not blowing fluid across, what we're doing is we're changing the pressure in the chest, and it's going to cause that diffusion of fluid back to where, out of the interstitial space back to where it needs to be into the intravascular space. Okay, so that's why CPAP is really the gold standard on left-sided CHF. The right-sided CHF, these are the patients that we get there and like they're sitting in their chair, they sleep in their chair in the recliner. You can tell that this is where they spend all of their time, and their lower extremities from their knees to their ankles are just so swollen, right? You push on their shins and it takes like 4 or 5 seconds for the skin to even start coming back out, right? So you'll hear pedal edema, like, oh, she has 3+ pedal edema. That means it takes 3+ seconds for that to come back out, okay? These patients, whenever we go to move them, any cardiac patients or respiratory patients, we don't want them walking to the stretcher. So we may have to pick these patients up and put them on our stretcher. Just be careful because sometimes if the lower extremity edema is significant, whenever you actually go to grab their legs to pick them up, whenever you squeeze their legs, it's actually going to weep out of the tissues. Just be cognizant that you need proper BSI for that. Oh, these patients will also, if you look at the other side, on the right side at the bottom, a desire to sit up, these patients will not want to lay down. They need to sit up. So also, if you look at they're in their bed, they sit on a big old stack of pillows, right? They don't sleep flat because they can't breathe whenever they lay down. Okay. What do I need to talk about? Okay. Altered mental status. So altered mental status. So these next few chapters are going to go pretty quick. So, you know, you have 10,000 mnemonics that we've already kind of gone over through class. This is another one to give you an example of altered mental status. Remember, there are 3 things that your brain needs in order to be awake: oxygen, sugar, and space. So when we have patients that are altered, these are the patients that I need to, whenever you're doing full set of vital signs. Not every patient you do vital signs on. A CBG is not a vital sign, but it is a tool in my toolbox. So unlike vital signs, which are blood pressure, pulse rate, respiratory rate, and pupillary response, now this is maybe where I need to get a CBG. and I need to get an SpO2 on these patients, okay? Because that's two things that your brain needs in order to be awake. Not every patient needs a CBG. Not every patient needs a pulse ox on them. Use what's appropriate for your patient. But these are just some things that can cause an altered mental status, right? Okay, so just kind of look over them, get used to this list. Again, it's another mnemonic, kind of helps you remember things. Strokes are another thing that we deal with. There's two types, right? So I have a hemorrhagic stroke and I have an ischemic stroke. Hemorrhagic strokes are obviously like an aneurysm. It blows in their head. So these patients are the ones that whenever I deal with them, these patients will tell you that yeah, that we have sorry, somebody came to the door and it like totally threw me off. Okay, so this is like typically bleeding that goes on in the subarachnoid space, right? These patients, unlike an ischemic stroke, cannot have a thrombolytic because what happens is if we take them somewhere and they end up with thrombolytic therapy, which is a clot busting medication, it's going to just make the bleed worse. Okay, an ischemic stroke is whenever you have a clot. Okay, so I have an thrombus, which is like a big clump of plaque in the vessel, and then a piece of it breaks off and it becomes an embolus, and now it's on the move, and it goes through. This example is where vessels bifurcate, they come together, and it's going to stick to the next thrombus. Well, then it occludes the blood flow. Okay, so these are ischemic strokes. These patients are the ones that whenever we are able to transport them to definitive care, which is they need a CT and they need somebody that has thrombolytics or fibrolytic therapy, then these are the patients that they're going to give them the medication. It's going to bust up the clots and it's going to free the blood flow. Okay. So that's the difference between the two strokes. Okay. A TIA, transient ischemic attack, is something that we see. So a patient may potentially have stroke symptoms, but they usually go away between 15 minutes and 24 hours. If they resolve within 24 hours, it's a TIA. TIA people call, oh, it's a mini stroke. Well, there is research that's done that basically says that if a patient has a TIA, within 3 months, they're potentially going to have a major stroke. So they really need to see a doctor. Please do not take these patients and be like, well, you know, your symptoms passed. It's really okay. Sign a refusal. No, these patients need to be seen. Okay. Y'all, something else, it doesn't have to be just like we're going to do this nice stroke scale, but it doesn't have to be like major face drooping or my arm just doesn't move at all. These patients can be like, you know, I'm holding my glass of tea and then all of a sudden, like, I drop it on the floor. Like I can't hold it. So you just have like really marked weakness, paresis. Okay. It doesn't have to be just paralyzed. Or you have patients that, depending upon where the stroke is, if it's in the cerebellum of their head, like maybe they're walking and they have that ataxic gait. So they kind of walk like they're drunk and they lean up, or like you're on a boat and you don't have sea legs. And so their gait's off. Okay. That's still a stroke. It just isn't a different part of the brain. Okay, so signs and symptoms of a stroke we just kind of talked about and alluded to. Okay, so we in the field do the quickest way to do it, like your book talks about the Los Angeles strokes, pre-hospital stroke scale. Yeah, we don't really do that one because that one's a little more elaborate. This one's just really quick. So on the facial droop, again, you know, ask your patient to smile. Show me your teeth. Smile big, big. All right, arm drift. Please make sure that you have your patient close their eyes on this. These people know something's wrong, y'all. They know that something's not ordinary. Everybody knows what a stroke is. Oh my God, I'm going to be paralyzed for the rest of my life. I'm going to lose my independence. My kids are going to put me in a nursing home. I'm not going to be able to feed myself. I can't walk. I can't drive. I can't, right? The anxiety level is through the roof. So what we want to do is we want to kind of decrease that. So on this arm drift, please have your patient close their eyes, and then you take their hands and hold their hands up in front, right? Oh, you hold their hands and you tell them, okay, what I'm going to do is I just want you to hold your hands right here, leave them up. And then whenever you let them go, don't just let them go. just let them go. But if their hand starts to droop, catch their hands and put it back where it is before you have them open their eyes. Okay. It's very simple, y'all. It's common sense. Don't just say, hey, can you raise your arms? And then my patient can raise one arm and not the other one, and they start freaking out and their blood pressure goes up and make the stroke worse. And then have them do something simple. You can't teach an old dog new tricks. Everybody kind of knows that one. You can just tell them, look, I need you to repeat 3 words back to me. Tree, school, yellow, and just see if they can repeat it back. All we want to do is, I need to know, can they get from here to here? That's it. Okay. And if they start struggling and they're trying to talk and they just can't get it out, don't sit there and wait and go, okay, come on, finish. You can say it. Come on, keep going, keep going. If they can't say it, okay, it's not a big deal, not a problem. We're going to move on. Okay. In the field, we also kind of do the can you squeeze me? Can you wiggle on the hands and their feet? Can you press the gas pedal, just for an extra test that we do that is not part of the Cincinnati Stroke Scale. The Cincinnati Stroke Scale is only these 3 parts. Okay. But you can do, because typically we do upper, and I just want to know too, does it affect the lower? So we'll ask them, can they pull their toes to their face, or can they push like they're pushing a gas pedal? Check pulses in all 4 extremities. Okay. All right. Types of seizures. So I'm not going to go over all of these. Again, this is in your book. The big ones to know is a tonic-clonic, what used to be called the generalized seizure, or a grand mal seizure. Febrile seizures we'll talk about. Partial seizures. Yeah. Okay, so let's go back to this one. Okay, so tonic-clonic seizures. This is like grand mal. All right. So you need to know the phases of the seizure, a grand mal or a generalized. My whole brain is working, is like a lightning storm. It's short-circuiting. You need to know some patients have an aura, some patients don't. Auras can be, they see a flash of color, they have a funny smell, they have a funny taste in their mouth. Not everybody has an aura. Then you end up with if you remember, the tonic phase is the muscle rigidity, right? So tonic, kind of like gin and tonic, makes you walk all weird, right? Like a baby giraffe. So it affects your muscles. And then a clonic starts with C. Convulsions start with C. So this is actually the jerking. It is not like you see on TV where these patients are doing all of this. It's typically where my patients, okay, so muscles get super tight and then they're going to jerk. So it's not this whole big flailing thing that happens on a real generalized seizure. What we want to do is we want to protect the patient. So if the patient is seizing, we roll them on their side, we move furniture out of the way. Do not put anything in their mouth. It is impossible to swallow your tongue. That is I don't even know what, wives' tale, whatever. Your tongue is rooted in your mouth. You cannot swallow it. It can fall into the back of your airway and cause snoring respirations. And then if your jaw locks, they get trismus, then it's very hard to lift the tongue off the back of the airway. That's why we turn them on their side. Not only that, but remember that while you're seizing, you're not breathing. And you also cannot control the secretions in your mouth. So if I turn them on their side, if they bite their tongue or they just have extra saliva in their mouth, it can pull on one side or come out. So that prevents me from having an aspiration issue. I've prevented them from hurting themselves. And this also gives you a chance where I can put a non-rebreather on my patient and give them oxygen, because remember, a generalized seizure, my whole brain is working in electrical storm, and every muscle is paralyzed. Your diaphragm is also a muscle, so my patient is not breathing. Febrile seizures most of the time happen between the ages of 6 and 6, so 6 weeks to 6 years. And these are patients that it's not necessarily that I have a fever of 104. It's the fact that I went from 98.6 to 104 in 0.2 seconds, and then my body has not had a chance to compensate. Okay, so that's what causes the patients to have seizures. They go from one extreme to another. We never want our patients to go from one extreme to another, because there's no compensation and your body's not going to know what to do. So it causes a potential seizure like febriles. Let's talk about absent seizures real quick. So absent seizures, a lot of times these are the ones that, like, have you ever like driven somewhere and you get like 3 hours down the road and you're like, man, I don't even remember going through like Jennings. I'm driving to New Orleans, right? Do you daydream? Yes. But if a child is daydreaming a ton and they just are not, like, may not be just daydreams. It can be actually be absent seizures. So make sure you get a good history on what's going on from parents or from your patient, family, bystanders, whoever. Okay, so partial seizures, it's just one hemisphere of the brain. Remember that your RAS isn't really an organ system, right? Your reticular activating system, it's not really like a body system. It's basically just a light switch. So I need one hemisphere of my brain to work and a light switch to turn it on. Partial seizures are just that one half of my brain isn't working. So, or it's in an electrical storm, it's in a seizure. So it's going to affect whatever that is, right? So typically if I have a seizure on the right side, it will affect the other side of my body because your motor goes contralateral, it crosses over. So that's why, like, if I have a stroke on the right side of my head, then my left side is actually affected because your motor crosses over. Okay. This is in your book. Again, we just talked about that stages. Okay, so you get an aura, you do the tonic phase, you do the clonic phase, and then you're post-ictal. So post-ictal basically is you've used all the oxygen and sugar reserves in your body, and your body's just extremely tired. So sometimes we get there, my patient is post-ictal. Sometimes they've also urinated on themselves or defecated because you lose body function. Please make sure you protect your patient's modesty on that, and talk to your patient. You don't know when they can come out of their mental fog, and they actually can hear you, but they may not still be able to move. Please make sure that you're talking to your patients to reassure them that everything's okay while they're post-ictal, okay? Status epilepticus is basically 2 or more seizures without a break in between. So your book says up to 30 minutes before it's status. If you think about where we're at, 4 to 6 minutes, we start killing off brain cells. So anything over 5 minutes technically is status. You need to make sure that we are oxygenating these patients, call for ALS backup because we need to break the seizure activity that's going on. Okay, last section, diabetes. So this is what happens normally, okay? So my normal blood sugar range is from 70 to 120. Okay, like that's the range I want to be in. So typically what happens is we eat something, it's broken down, the carbs, right? Carbs, fats, proteins. Carbs is the main source that we use. It's broken down, sugar gets into my bloodstream. If I have a normal pancreas, it secretes insulin. Insulin's a little key in my blood vessels that in my bloodstream that basically goes up to my cells. It unlocks it. Sugar goes from my bloodstream into my cells, right? Because we're going to need that for aerobic metabolism. If you have a diabetic patient, what happens is that either they don't produce any insulin, so there are no keys to open the doors on the cells for the sugar to go in, or they produce a little bit of insulin, but it's crap. Okay, so the keys are broken and they don't always fit and the doors don't always open. So if you eat something, I eat, it gets broken down, I have sugar in my bloodstream, it goes into my cells, and everything is working like it's supposed to, right? Then whenever I have all my sugar got into the cells, there's none in my blood. Well, then my body needs to have more sugar, right? It's a cycle. So what does it do? It says, okay, hey, liver, I need you to let go of some glucagon and glycogen from the pancreas so that way, hey, I got more sugar that's going to be in my vessels. So when you produce a bunch of sugar, your body says, whoa, I got too much sugar in my bloodstream. I need to produce insulin because it needs to open the doors and let it go into the cells. Okay, it just keeps going and keeps going and keeps going. So whenever we have a patient, okay, here it is right here. I forgot this was on here. So if you look right here, it's right to my cell. My insulin comes in, it opens the door. So here's my keys in green, puts the key in the door. My little door, which is pink, opens. My sugar goes in. I can produce my energy. This is going back to module 1, chapter 8. And this is how I stay in aerobic metabolism, right? I have oxygen, I have sugar, everything's good. I produce all my little ATPs. My cells are fat and happy, and everything's good. Okay. Whenever we have a patient that is between insulin dependent and non-insulin dependent. Okay, so type 1 is insulin dependent. It is type 1. It's found in the first stages of your life. So these are usually like kids that find out. Doesn't have to be like children. It could be adolescents, it could be teenagers, whatever, but it's found in the first part of life. These, unfortunately, because their insulin is crap or it doesn't produce any from the pancreas, these are the ones that have to take the shots. Okay, so they're insulin dependent diabetic mellitus diagnosed. Non-insulin dependent, which is type 2, found in the later stage of your life. These are the ones that, like, okay, if you control your diet, if you exercise, or you can take pills, glucophage, things like that, then you can maintain your diabetes. So these are non-insulin dependent diabetics. Okay. All right. So the difference between these hypoglycemic patients, hypoglycemia, these people are normal, everything's fine. And then all of a sudden their blood sugar drops. Like, so if you have somebody that is hypoglycemic, they don't necessarily be diabetic, right? You can be having a stressful day. Maybe you exercised a lot, you didn't really eat, and then all of a sudden you get the shakes, right? So you drink a Coke, you eat a candy bar, and everything's good. You had a hypoglycemic episode. Doesn't mean you're diabetic, right? These happen acutely. So everything's good, everything's fine. We're cutting up, we're having a good day at the pool or whatever. Then all of a sudden you look over and, oh, Bob here, he looks like he's drunk, right? We need to check a sugar because it could be a hypoglycemic episode. Hyperglycemia, on the other hand, is very slow progressing. This is like over a few days. You get the 3 polys, P-O-L-Y, 3 polys that visit. So polyuria, they're peeing a whole bunch. Polyphagia, with a G, they're eating a whole bunch. And polydipsia, you dip a straw in a drink, they're thirsty. So whenever we're getting our history, we're asking about these. That's going to be like 3 of the unique findings for that. A patient can be hypoglycemic at anything less than 70. Okay. We need to treat that anything less than 60 if they are having signs and symptoms of the alternate status, the skin changes. Below 50, regardless. Okay, give them some sugar. You do not need the whole 15 grams of glucose. You can just bump them until their mental status changes, and then they need something more substantial to eat. I don't know, peanut butter and jelly sandwich, eggs and toast, whatever, because they need those carbs to break down, not just sugar. Hyperglycemia is anything over the 120, right? Our machines that we use in the pre-hospital world will tell if a patient is hyperglycemic. However, when they get up to the diabetic ketoacidosis stage, which is usually anything over 300, they're in DKA. So what happens, instead of using carbs, my patient uses fats, and whenever fats are broke down, ketones, right? So, you know, people are like, oh, I'm on keto diet, right? They're on eating a bunch of fat. So they break down fat. When they break down fat, they release this, like, your book talks about a fruity odor. Okay. It's not like oh, it smells like strawberries when you walk in the room. It smells like juicy fruit taste. Okay. So it's like very faint that you can smell this on a patient's breath. I mean, you got to be like pretty close to it. So like whenever you're actually like in the nitty gritty dealing with your patient, they're going to have a ketone smell. Okay. Again, this is anything that's over like 300. HHNK or HHNS, hyperglycemic, hyperosmolar, non-ketotic syndrome. So these patients are having a hypoglycemic episode. They are hyperosmolar. So they're also, we need to look for a dehydration issue because there's a whole lot of water change going on. They're non-ketotic, so they're not burning fats. There's going to be no ketones syndrome. Okay, so these patients are the ones that like their blood sugar is like above 500. It's like 800. They basically, our machines in the street are going to read high. We're going to take blood at the hospital, and it can be upwards of like 1200 or greater. These patients need to be on an insulin drip. We do not give insulin in the field. It's a double verification drug. So they're actually going to be on a machine at the hospital for a couple of days. Okay. Again, anything hyperglycemic takes days to come up. Hypoglycemia can be an acute onset. Okay, I think that's it. I've gone through everything. Again, if you have any issues, if you have questions about anything, if this has helped, you can always send me an email, tell me that it's helped you out. If there's anything, questions that I can answer that your local instructor is, not exactly vibing with you, or you kind of just need a second opinion, it's always good to ask another instructor. My kids here in Lake Charles, I tell them to go talk to the other instructors too, because maybe I'm just not explaining things a good way that you're understanding. Okay. Again, this is a huge test. It's a lot of information. So please reach out to the other instructors at your site. You're more than welcome to send me an email. Again, first initial K, last name Doge at Acadian.com if there's anything that I can help you with. Okay. Good luck on Module 5 exam. Good luck on completing EMT 1 with a 75, and hopefully we see you moving into EMT 2. Okay. Have a good day.